Thank you so much for that very good introduction. And I'm sorry the video part is not working, but I'm going to talk about hypothermia for HIE, discuss current status and controversies, and then hopefully we'll have some time at the end for questions. So first of all, what do we know about hypothermia for neonatal HIE? So there have been a number of very well done randomized controlled trials in the high income countries. And this is a slide that shows you the data from the CoolCap, the NICHD, the TOBY, the European trial, and the ICE trial, which is in Australia. So you see the rate of death or disability in infancy between the hypothermia and the control groups. In all the studies, there was a reduction in the hypothermia group. And in the NICHD trial and in the neuro trial, this reduction was statistically significant, as you can see here. I've marked these in red. So also in the ICE trial, where there was a reduction from 66% in the control group to 51%. If we look at the rate of cerebral palsy in infancy, in the same trials, again, you see a reduction between the control group and the hypothermia group. There was a significant reduction in the TOBY trial, 41 to 28%, and the European trial, 48% to 12%. In the neonatal network trial that we did, the rate was lower, but it was not statistically significant once we adjusted for the stage of encephalopathy. Now, keep in mind that the rate of death or disability in the trials was around 44%. So we have more recent data of your second column, which is the usual care cooling group in the optimizing cooling strategies trial, which was looking at longer cooling and deeper cooling compared to usual cooling. And what you see here is that the rate of death or disability in infancy is reduced from 44% to 29%. And the reduction is seen in both moderate HIE and severe HIE. And the mortality rates have really gone down from 24% to 9%, with an increase in the cognitive and motor outcomes. Interestingly enough, in the network study, the rate of cerebral palsy stayed really the same from the 2005 data to the 2017 data. So we saw that neuroprotection was effective at 18 months. Does this persist to childhood? It's important to look at the longer-term protection. And the CoolCap trial did present 6 to 7 year outcome of about half of their surviving children. They did an interview screening. It's called the WeFM. And what they found was that the disability status at 18 months strongly correlated with disability as represented on the WeFM questionnaire. This is the data from the NICHD trial, where the primary outcome in childhood was death or an IQ less than 70. We had a very good follow-up rate in both hypothermia and control groups. And you see that the rate of death or IQ less than 70 was lower, 47% in hypothermia compared to 62% in control. This was significant when it's unadjusted. But when adjusted for stage of encephalopathy, it was not significant. And the third trial that reported childhood outcomes was the TOBY trial, and their outcome was survival with an IQ equal to or less than 85. So when you looked at that, they did have, loss to follow up in both groups of around 18 subjects. But they did find that the rate of a primary outcome of an IQ greater than 85 was much higher in the hypothermia group compared to the control group, 52% versus 29%. So what this data shows from these three trials is that the beneficial effects of hypothermia seen at 18 months of age did persist to childhood. So now let's look at another question. Can we get better neuroprotection with longer cooling or cooling for a deeper temperature or a combination of longer cooling and deeper temperature? And the reason for this is that there was some data, preclinical data, showing that the brain of injured models shows that the temperature of the basal ganglia thalamus is actually higher in severe injury, and this was confirmed in spectroscopy in infants. And once you start hypothermia, this brain temperature actually gets lowered. So it was done where the primary outcome was outcome at 18 months of age. Here we show a comparison between infants cooled to 72 hours compared to those cooled to 120 hours. And the primary outcome of death or disability remained totally unchanged, 32% in two groups. On the other hand, mortality actually was increased when you increase the duration of cooling to 120 hours, from 13% to 19%. That was a significant increase. The rate of moderate or severe disability alone and the rate of cerebral palsy was not changed. So there was no beneficial effect of longer cooling. Now, if you look at cooling to 33.5, which is what is done clinically, and compared it to lowering the temperature further to 32 degrees, once again, you see that the primary outcome was unchanged with the deeper cooling. Mortality again went up a little bit with the deeper cooling. So what this shows is that the standard cooling that we have now, which is 33.5 to 72 hours, is probably the best approach for the present time. So moving on to, we know what the outcome is at 18 months of age. And of course, when you do studies and you need 18-month outcome, the studies do take a very long time. So the question is there an early biomarker that correlates well with the later outcomes? So we looked at this. We looked at the brain imaging using the MRI score. And here what we show is that on the left-hand column, the higher the degree of brain injury on the scoring system we used, the higher the rate of death or disability. So this was significantly associated. It was also associated with that the higher scores showed less survival with no or mild injury. So this was a good correlation between neonatal MRI and 18-month outcome. We also looked at the relationship between neonatal MRI and 6 to 7 year outcome and compared infants who had an IQ above 70 to those who were disabled with an IQ less than 70. And you can see that in every area of the brain that we evaluated, the children with an IQ less than 70 had a much higher rate of signal abnormality in the neonatal MRI, whether it was the cerebral region, the basal ganglia thalamus, etc. Again, same findings with the posterior limb of the internal capsule, watershed areas, and hemispheric brain injury. So what this shows is that neonatal MRI is a good surrogate of 6 to 7 year outcome. The TOBY trial has also presented the brain injury and association with outcome. Here you see that in the subgroup of infants that had an MRI evaluated, the hypothermia group had a reduction in signal abnormalities in the basal ganglia thalamus, white matter, and the posterior limb of the internal capsule. And the MRI, the neonatal MRI, was a very good predictor of death or disability at 18 months in both the cool group and in the non-cool group. And here is data from the ICE trial. Again, a subgroup of 128 infants among the trial participants had both MRI and diffusion-weighted imaging. And what they noted was that the hypothermia infants had reduced white matter imaging and cortical gray matter abnormalities. And there was a very good association between the 2-year outcome and the abnormalities noted in the neonatal MRI in the posterior limb of the internal capsule and the basal ganglia thalamus. This shows us that the neonatal MRI is a good surrogate of childhood outcome. And now we see more recent data with advanced neuroimaging looking at magnetic resonance spectroscopy. And this is a multi-center, multi-country trial that we participated in with called the Marble Study with 225 infants. And what the data showed was that if you measure the NAA concentration, the absolute concentration of the N-aspartyl acetate, the infants who had a normal outcome had much higher levels as opposed to infants who had an adverse outcome who had much lower levels. So this was a good separation of normal versus abnormal, looking at absolute NAA values. Now, when you look at the more traditional lactate to NAA ratio, you see that the normal infants had much lower lactate to NAA ratios compared to those with adverse outcome. And if you look at the NAA to choline and the NAA to creatine ratios, you see that there's again a separation between normal and abnormal outcomes, with the normal infants having higher ratios. And this was published in 2019. The other interesting part was that an association with the absolute NAA value and Bailey scores, the cognitive score, the motor score, and the language score was evaluated. And what you see here is, for example, in red are the infants who have severe abnormalities, and you can see that in the 3 domains of the Bailey, the severe infants have much lower values as opposed to those who are moderate, which is in yellow, and the ones who are mild, which is in green. So there was excellent correlation with the Bailey scores at 2 years of age and the MRS data. In fact, when the investigators put all the data together, they found that if you look at the area under the curve, if you look at the discharge neuro exam, it's about 65% correlation. If you look at the MRIs, it was around 70%. The cortex, the basal ganglia was better. If you look at diffusion-weighted MRI, it's actually a better predictor. And then when you look at spectroscopy, and you look at the ratios first and you look at the absolute level had the highest correlation of value with the outcome at 18 months of age. So this is a good predictor of outcome. Let's move on to a couple of other questions that have been raised. Is hypothermia effective for moderate or severe HIE if it is initiated between 6 and 24 hours of age? So this is for infants who were normal prior to 6 hours and then became abnormal, or they arrived at the cooling center late after 6 to 24 hours of age. So this was an NICHD network trial and published in 2017. And what was shown was that when you look at the frequentist analysis, The rate of death or moderate severe disability was 24% and 27%, so a little bit lower in the cool group. But if you do the Bayesian analysis, you do see that the posterior probability of benefit is about 76%. So what this means is that there's some evidence that you can offer cooling between 6 and 24 hours of age for these infants who present later. When other outcomes were looked at, you can see that the cognitive language and motor scores on the Bailey were slightly, better, marginally better in the cooled versus non-cooled, but really no statistically significant difference between the two groups. But I think this is the only data that we have based on a trial. So the next question, which is really important, is what I've shown you so far is hypothermia for moderate or severe HIE in the high-income countries. So is hypothermia effective for moderate or severe HIE in the low and middle-income countries? So this was a trial that was published in last year. It was called Hypothermia for Moderate or Severe Neonatal Encephalopathy in LMIC. It was called HELIX. It was an open label phase 3 randomized controlled trial with masked outcome assessment. So these were the Bailey assessments that were done by trained examiners. The trial was very robust. It included 408 term babies with moderate or severe encephalopathy from 7 tertiary neonatal units in South Asia, the majority from India, 1 from Sri Lanka, and 1 from Bangladesh, as you can see in the map. The intervention was in the control group. What was really important was that the infants were provided intensive care, and it was also care was taken to avoid any elevation of temperature in the control group. So it was maintained between 36.5 to 37. The intervention group got whole body cooling, 33.5 degrees Celsius for 72 hours using Tecotherm Neo, which is a server-controlled whole body cooling device. Primary outcome was death or moderate or severe disability at 18 to 22 months, with the definitions that were based on the NICHD Neonatal Research Network. So here are the characteristics. When you compare the hypothermia group with the usual care group, there were really no differences in baseline neonatal characteristics between the two groups. Of note is that they had a lot of outborn babies, as you can see. pH was really low, etc. 80% were moderate encephalopathy in both groups. The other thing to note is that there was a very high rate of seizures at randomization within 6 hours of age between the two groups. Now, at hospital discharge, the outcomes did show that there was an increase in complications in the hypothermia group compared to the control group, as you can see from this slide. Increase in gastric bleeding, persistent hypotension, pulmonary hemorrhage, prolonged blood coagulation, and severe thrombocytopenia. And mortality before discharge was higher, 36% versus 24%. So this was more serious adverse events in the hypothermia group. And when we looked at outcomes at 18 to 22 months, the primary outcome of death or moderate to severe disability was unchanged, 50% and 47%. Mortality prior to 18 months was 42% in the hypothermia group and 31% in the usual care group. So mortality was significantly increased. When you look at all the other components of disability, there was no difference between the hypothermia group and the usual care group. Spectroscopy was done in a subgroup of infants, And what was noted here was that there wasn't any difference in the NAA concentration in the neonatal MR between the hypothermia and the usual care groups, as you can see. And then when you look at the lactate to NAA ratio, again, there was no difference between the hypothermia and the usual care groups. So why are the results of the HELIX trial different from the high-income RCTs? So HELIX had more outborn infants, 67% compared to 45 to 64 in the other HIC trials. The babies were smaller in size, but again, this is India, so the babies are smaller in size. Interestingly, very few perinatal sentinel events, only 11% compared to 2 to 3 to 4 times higher, much higher in the HIC trials. There were fewer emergency cesarean deliveries, only half as those of the HIC trials. There was a very high rate of seizures at less than 6 hours of age. As you can see, 74 versus 33 to 61, which is the HIC trials. Fewer control groups had at least one episode of hypothermia. This is important to see because in the HELIX trial, the control group had targeted temperature management and they were all kept within the normal range. Whereas in the high-income trials, you'll see that the control group infants had at least one elevation of temperature above normal, ranging between 14 to 38%. And we know that, having elevated temperature is associated with death or disability. The other interesting thing was that in the MRIs that were done in HELIX, there was more white matter injury compared to what is seen in the HIC trials, where you get a lot of deep nuclei injury, basal ganglia thalamus. Now, in HIC, in HELIX, the fetal environment was not assessed because there wasn't enough data on the antenatal and the intrapartum status. So that has to be acknowledged. So the conclusions of the HELIX trial was that cooling therapy did not reduce death or disability or brain injury at MRI. Instead, there was increased mortality. So the question is, among the HELIX infants, the brain injury was possibly, it occurred in the perinatal period. And is this some form of acute injury on a chronic hypoxic-ischemic injury or a subacute type of hypoxic-ischemic insult? You will remember that there were very few perinatal sentinel events, very few emergent C-sections. So it appears that the type of infant is different in the HELIX trial participants compared to the HIC trials. Now, can certain group of infants in the LMICs, those who have acute perinatal sentinel event, can they benefit? We don't know that as yet. So we've covered most of the evidence-based data on hypothermia. Let's look at hypothermia plus therapies. So you will recall that at the PAS meeting this year, the hypothermia plus EPO trial results were presented. It was found that hypothermia plus EPO was not beneficial compared to hypothermia alone. If you look at other drugs now being evaluated, melatonin, umbilical cord cells, and allopurinol are being tested. So we need to wait for those results. What we do know is that xenon, magnesium sulfate, and topiramate have not been shown to be beneficial from the randomized trials. So future studies that should be done should be adequately powered because the current rate of death or disability, as I've shown you, is 29%. So the sample size should be adequately powered. And of course, the gold standard is still neurodevelopmental outcome at 18 to 24 months. Now I'm going to shift and talk about controversies in the use of hypothermia. And these include cooling for mild HIE infants, cooling preterm infants, and cooling infants for other conditions like postnatal collapse and severe surgery, such as NEC, which was published. And then lastly, I wanted to touch on the use of sedatives and analgesics during hypothermia for HIE. So there was one report in 2014 where hypothermia was used for other conditions such as more than 6 hours of age collapse, postnatal collapse, hemorrhage, congenital cardiac disease, and surgical conditions. And of all these, there is no evidence of safety or efficacy in any of the above conditions. And I've shown you the data about cooling infants within 6 to 24 hours of age from the network trial. So let's focus on mild HIE first. So there have been a couple of meta-analyses. I'm just showing you one where therapeutic hypothermia for mild neonatal encephalopathy was reviewed. As you can see, there have been a number of studies. And if you look at the event rate and the total number of infants in the studies, they are really very, very low. And of course, if you look at the results, there does not appear to be any favoring of cooling or not cooling. In spite of that, though, there have been surveys that have shown that many centers in the United States, UK, and Europe currently are cooling infants for mild HIE. And the registry data has published, this is the Vaughan data, Vaughan Oxford Network, the TOBY data in the UK, and the Children's Hospital National Database in the United States. All three registry data have actually shown that more than 1,000 babies with mild HIE have been cooled. Unfortunately, there's no outcome data presented from the majority of these reports. Now, the more recent data, I'm talking about data after 2020, is even, to me, more concerning. For example, this is from the United Kingdom. It's a national population study, and you can see here that 1,050 babies with mild HIE were cooled, while 2,330 with mild HIE were not cooled. And if you look at the registry data from the Canadian network, this is data from the Canadian network, they had infants with mild HIE, 393 were cooled as opposed to 696 that were not cooled. And if you look at the variables evaluated, you can see that the infants who were cooled had much higher rates of complications such as gavage feeding, PPHN, renal failure, hepatic dysfunction, cardiac dysfunction, etc. And of course, many of them received opioid infusions, and they had a longer length of hospital stay. This is data from the state of California, recent data from the state of California, registry data that again shows you 967 babies with mild HIE cooled and 307, excuse me, I'm controlling this, 397 receiving supportive care. And you see that the infants who have received hypothermia actually stay on the ventilator longer and have a much longer duration of intubation. What about imaging in infants with mild HIE? The reports are very variable. Evidence of brain injury on the MRI in these infants ranges from the reports from as low as 11% to as high as 40%. And it depends on whether the studies are retrospective or prospective, or if cooling has been received or not. it appears that the injury is more in the watershed areas as compared to the deep nuclei. And there have been a few mild HIE infants who were included in the randomized controlled trials, and 2 meta-analyses have been published. But you can see when those specific mild HIE infants were evaluated, adverse outcome was not statistically different between the ones who were cooled and the ones who were not cooled. So the bottom line is that we have no data at the present time of the safety or the efficacy of cooling infants with mild HIE. So we do need a randomized controlled trial. We should select the infants at highest risk. We should be very clear on how mild HIE is diagnosed. We should use the current depth and duration of cooling, and these infants should be followed for at least 5 years of age, because mild HIE is usually associated with cognitive and behavioral outcomes. So you do need a large sample size and a 5-year outcome study. If cooling is found in a trial setting to be safe and effective, then it can be offered. But if it's not found to be safe and effective, this should be discontinued. So this was an editorial that was published in 2020. There are, however, a few studies on infants with mild HIE. I got this data from clinicaltrials.gov. The first is called Comparative Effectiveness for Cooling Prospectively Infants with Mild HIE. It's the CoolPrime study. It's going to be an observational study, a longitudinal observational study that's going to compare the receipt of therapeutic hypothermia or no cooling based on the center practice. So, I'm not sure how this is going to work, but it's going to enroll 460 infants, start enrolling later this year. The outcome, primary outcome, will be the Bailey-4 domains between the infants who were cooled as part of an observational study versus those who are not cooled. And the PI is Lena Shalak. The study is mild encephalopathy in the newborn treated with darbepoetin. This is a phase 2 multicenter placebo-controlled trial. Infants are not cooled. They are given a dose of darbepoetin, 10 microgram per kilo as a single dose, or they're given normal saline. And they're followed to 24 months of age. It's a small study, 34 participants. And, we're waiting for the report of this study. The PIs are Tara DuPont and Robin Olds. Third study is the TIME study, which is a randomized controlled trial. It's therapeutic hypothermia versus targeted temperature management in the control group. So that is ideal. The primary outcome is, however, 12 to 14 months of age, using the WIDEA and the AIMS. These are 2 questionnaires and evaluations. It's going to have 68 participants, so not a very robust study. And the PIs are Sonia Bonifacio and Chrissa Van Meers from Stanford. They updated their information on clinicaltrials.gov in March of 2020. Let's look at cooling preterm infants. That's the next controversy. So, hypothermia for preterm infants, it was suggested in the AAP guidelines by Papil in 2014 that infants who are 35 weeks can be cooled. And of course, we know now that all the registries, TOBY trial and the TOBY registry and the VAUGHN registry, has cooled preterm infants. And 2 of the randomized controlled trials for HIE done in the high-income countries did enroll a few infants who were 35-week gestation, but there's no outcomes presented on that group. There is one single-center study published in 2018 that reported 30 infants between 33 to 35-week gestation who were cooled. The primary outcome was death or moderate severe neurodevelopmental impairment. What they found at hospital discharge was that the rates of coagulopathy, seizures, hypotension, as you can see there, persistent acidosis, thrombocytopenia was noted in the infants who were cooled. There were 4 deaths. Among the survivors, only 18 of them were followed, and the primary outcome was reported only on 11 out of the 22, so that's 50%. And had death or disability, but 8 of the infants have unknown outcomes. So the question really is not clear at all what we should do. There is an ongoing randomized controlled trial of hypothermia for preterm infants in the NICHD Neonatal Research Network with Roger Fakes as the PI. The trial is going to look at safety, all the issues I've raised here, and the trial is also looking at primary outcome, death or disability at 18 to 22 months of age. The sample size is 168 infants, all of which have been enrolled, and the study is almost finishing up the follow-up of these infants. So we are anxiously looking for the report from this trial. And then the last thing I want to talk about is sedatives and analgesics during hypothermia for HIE. So preclinical data has shown that hypothermia was effective only in the sedated model. And we also know that adults and pediatric patients, when you cool them, and that's usually done for cardiac arrest, then the individuals shiver very severely, so they have to be sedated. But there has been one publication in 2018 from the Neonatal Network that demonstrated no benefit of sedation analgesia in the group that received it compared to the group that did not receive it. Now, that was an observational study. We also know that there is accumulation of morphine whenever sedation is given to infants who are cooled. And of course, an excellent presentation on parental concerns. Parents are concerned about morphine because they do associate it with end-of-life care and with addiction. So we need to be aware of these concerns. So in conclusion, I would say that hypothermia at 33.5 degrees Celsius for 72 hours is safe and effective for moderate and severe HIE in infancy and childhood. Early biomarker of outcome in infancy includes neonatal MRI and MRS. I think I've shown you some information that sedatives and analgesics should be used with caution. Neither safety nor efficacy of hypothermia for HIE was noted in the low-income countries trial, but we don't know whether specific groups will benefit. And I will conclude by saying in the following conditions, the safety and efficacy of hypothermia for HIE has not been demonstrated. Postnatal collapse, surgical conditions, preterm infants, and most importantly, infants with mild HIE. I'd like to stop and see if there are any questions.
Thank you, Dr. Shankaran. Thank you so much.